Great, thank you. So we'll move on to our second talk of the morning. A pleasure to invite Dr. Neo Han Yee to the stage. Han Yee is the incumbent head and the senior consultant at the Department of Palliative Medicine in Tan Tock Seng.
Thanks for having me on today. I noticed that there's quite a bit of representation from the Malaysian palliative care community. I just want to say hi and just want to reassure the trainees that palliative care is all right. It's a very addictive specialty. I come home and next day I still want to be a palliative care physician. Although I do have to check back my department about the 12.5% of people who might want to quit. So today my topic is about patients' best interest and life prolongation, whether it's compatible or not, right? So I'm going to start off with a case vignette, right? A rather extreme case, just to push the extreme cases to one end, and we can spend more time discussing the in-betweens, right? This is a case that we saw in our hospital, but it has been de-identified, right? So it's a 50-year-old Eurasian man, came in with a catastrophic intracranial hemorrhage and severe hypoxic brain injury. He's ventilator dependent and quite likely brain dead. Right? The only reason why we haven't certified brain death is because the spouse demanded that all life support continues at all costs, and she was verbally very aggressive and very litigious, and she refused the team to proceed with the necessary processes for brain death certification. She threatens to make a police report, she threatens to sue, and she says that I've never given you any consent to proceed with these tests. And, if you ever give up on my husband, right, I'll sue the hospital and make sure that it's well read on Straits Times. Right. Okay, so this is something that's not too uncommon to some of us. I noticed that there are intensivists amongst the crowd as well, right? Now, you can imagine that in such a scenario, right, what goes through the intensivist's mind is not going to be about best interests predominantly, right? The first thing that goes through is, oh, hell. I'm going to talk about family conferences. I have to potentially put in the ethics committee. I have probably to speak to my head of department, my CNB, and medical legal implications involved. Maybe I should just hang in there and pass on to the next consultant that takes over in 2 weeks' time. The usual, right? Okay, we still see this, although things I must say have improved over the past 5 to 10 years, right? So of course this thing hits the ethics committee, and these are the questions that we've sort of crafted, right? So is it ethically appropriate to continue burdensome, extraordinary life-sustaining treatment on the unilateral demand of a spouse when there is no overall benefit, right? Does the spouse in a patient that lacks capacity have the authority to refuse clinically indicated assessments? And, mind the typo there. Does the spouse have any legal grounds to sue the hospital for failure to seek consent or, on the grounds of medical negligence? Okay, just to put some of these things aside before even we talk about best interests. Right? Now, this case illustrates a case that fulfills the criteria of medical futility. There is no unified criteria that everyone accepts internationally about what medical futility means, right? But personally, I quite like what Professor Schneiderman has come up with, and he has modified this across the years. Now, quantitative futility refers to an improbability of an event happening, which means in your mind, you have to set a certain threshold. It may be 1 in 100, it may be 1 in 1,000, but below this certain probability, this numerical probability, you would say that it is not worthwhile to continue this line of treatment because the possibility of achieving the goal is just too little. So that's a probabilistic kind of understanding. And in qualitative kind of futility, it refers to any treatment that merely preserves a state of permanent unconsciousness or that fails to end total dependence on intensive care, and it's therefore considered non-beneficial or futile. Now you can see that the qualitative futility definition is much narrower. Here it refers almost certainly to PVS and PVS only, right? So to fulfill qualitative futility in this sense, it's quite difficult. But in this particular scenario, of this 50-year-old Eurasian man with hypoxic injury, I think if you let it run for a couple of months, he's quite likely to show himself as PVS if he's not already brain dead, right? So in this situation whereby we would, amongst the medical fraternity, classify this as medical futility, it would have been very appropriate to withdraw. And if you look at the American guidelines, this is the American Medical Association Code of Ethics, and I quote here, physicians are not ethically obligated to deliver care that in their best professional judgment will not have a reasonable chance of benefiting their patients. We are not obliged to provide treatment. Okay? And what about the local ethics code? Now, in the SMC ECG 2016 edition, I heard one is coming out soon. You must respect the patient's wishes, yes, but you are not obliged to provide or continue treatment that you deem inappropriate, non-beneficial, or even harmful. So be it on the international kind of guidelines or in terms of a local guideline, actually physicians are pretty protected. We feel that treatment is not going to confer overall benefit, especially in such an extreme case. We should not be worried about medical legal backlash. And what about an ethical or professional front? Because you can almost guarantee that family members are going to accuse you, of euthanizing their loved ones, giving up too early, killing them off because you want that ICU bed for a younger, fitter patient, blah, blah, right? So for the palliative care folks here again, okay, this is part of your exit exam, at least in a Singapore setting. You must be able to recite this in an exit exam, right? Okay. So people will ask you, between withdrawal of non-beneficial care or unwanted treatment versus euthanasia or physician-assisted suicide, how are you going to discriminate amongst these entities, right? So at least in Singapore, but not perhaps in certain areas of Europe and Australia, physician-assisted suicide and euthanasia remains illegal, right? So in Singapore's sense, murder can be legally comprising of a few components. So number one, you need a perpetrator. You have an intention to kill. The motive can be for money, for jealousy, for anger, for whatever, okay? And then there's that act of felony, that act of actually stabbing someone, driving a vehicle into someone, whatever you name it, okay? And the patient dies, so that's murder, right? So in euthanasia, you also have a perpetrator, a doctor or nurse. There's an intention to prematurely terminate life. You give a little shot of, be it some form of opioid or midazolam or potassium cyanide, and the patient dies. And therefore, in Singapore's setting, legalistically, euthanasia and murder is synonymous. Physician-assisted suicide is slightly different. Here, the doctor partakes in the process indirectly. He prescribes a lethal agent. Okay? The patient or the carer gets a prescription, self-administer it, the patient dies. So it's not classically murder, but you are indirectly involved in that process of killing. Right? Now, withdrawal of a futile treatment or an unwanted treatment is a different thing altogether. Here, the doctor or the nurse's intention is that, if there's a way in which I can help him continue his life in a manner that's acceptable to him, I would go ahead. Right? But I haven't got a choice here because the disease is so advanced, the burden of the disease and the burden of treatment is too heavy. And therefore, after discussion, I'm allowing for natural death so that death can come naturally as a result of the underlying advanced illness and the patient pass away comfortably under my care. So the intention is completely different from euthanasia and physician-assisted suicide. And therefore, I just want to assure everyone here that withdrawing non-beneficial treatment, so long as you can justify that it is non-beneficial, and especially if it's unwanted, okay, you should not worry about medical legal backlashes. Okay? Now again, just to put this aside, no one can sue you for malpractice, negligence, professional misconduct. Because first of all, we must understand what does this entail? What does this comprise of? There are a few criteria that the lawyers need to go through before they can sue us, right? So number one, there must be a duty of care established between you and your patient, a therapeutic relationship. Number two, there must be a standard of care that's sort of recognized within the fraternity, within at least the experts that debate it in court. And then there's this deviation of this professional standard, this yardstick, and then leading to significant loss or significant harm to the patient. So in this case, this particular vignette of 50-year-old man with catastrophic intracranial bleed, very few will contest with you if you say that further treatment is considered quite inappropriate and futile. It's not going to bring about any meaningful recovery to the CNS, and in fact, if we go and certify the patient may be brain dead, you see. So in such a situation, we should not really fear medical backlashes because this is how the court will view our professionalism and whether we have departed from standard of care and whether we are negligent in this whole process. Now we just go into a little bit more of a specific, okay? Now in order for them to sue us for withdrawing unwanted or non-beneficial treatment, they will still have to fall back on Boehm's test, which basically says that, so long as there's a responsible body of medical professionals of my same specialization standards, same on par with me in terms of my skill, and they agree with me that, my judgment is correct, I have not deviated from standard of care, then I'm fine. Okay? It doesn't matter if the other side, the patient side, produce another expert that holds a different opinion. So long as there is a professional body that agrees with you that you have not deviated from standard of care, we have not breached Boehm's test. And furthermore, okay, just to add on a little bit, it's not enough just to have a medical expert appear in court and say that I agree with you, you have not deviated from standard of care. The expert, the domain expert, must be able to justify to the court in a rational, logical manner why they feel that you have not breached standard of care, why they feel that this is the standard of care, and why you have not caused harm to the patient. So this is just for the background context, right? So now we take a step back. We have talked about an extreme case whereby clearly it is quite futile, or in today's language, we should not use the word futile anymore because it's so emotionally burdensome to mention the word futile to family members. It sort of connotes this giving up, this abandonment kind of emotion. What we would usually use is the word appropriate or inappropriate. Right? So when the burden of treatment outweighs its potential benefit, it becomes inappropriate. When the patient never wanted it in the first place, to continue it is inappropriate. So let us look at today's title of the talk, which is the patient's best interest and life prolongation, compatible or not. To answer this question, I broke this title up into three parts. Number one, what type of life prolongation are we talking about? It can go beyond the ICU, right? It can be routine use of antibiotics, nasogastric feeding in advanced dementia, fluids, for nutrition and hydration at the end of life, And number two, compatible with what? With what kind of standards, with what kind of clinical context? And lastly, compatible with who? Compatible with whose wishes? Now, for those who are not so familiar with the healthcare scene, okay, this is one potential way in which the healthcare electronic system will force us to stratify our patients, right? So on the dashboard on your computer, a patient in Tan Tock Seng would fall under these three categories: either, assume active resuscitation, partial code, or allow natural death. And of course, under each of these categories, there are different invasiveness and aggressiveness of treatment. So full active treatment would include the full works in ICU, including mechanical ventilation, high-flow nasal cannula, of course, CPR, and if you want, dialysis, ECMO, blah, blah. In a partial code, this is the case whereby a patient would stay in the general ward. If he were to deteriorate, he may go to high dependency, but he will never go to ICU. This belongs to a group of patients whereby their prognosis would not be too favorable, even if they go to ICU or if they express that they do not want ICU interventions. So this would include use of inotropic agents that bring up your blood pressure, IV fluids and antibiotics, and other non-invasive form of ventilation. And of course, allow natural death means to withhold all resuscitative efforts, but this does not imply withholding of all care. So please take note of that. Allowing natural death should mean that all efforts are directed away from aggressive invasive management, but towards full comfort-driven care to alleviate symptoms and allow death in a dignified manner. So when we then look at this question of best interests, okay, in our mind, we must think about all the potential interventions that we have for this patient that's sitting in front of us. We also have in our mind the various clinical characteristics of this patient to determine whether he's going to respond to treatment. Things like his age, his social-economical profile, his comorbidity burden, his response to treatment so far, how many organ systems are involved, blah, blah, right? So it seems to be a lot of things that's going through our mind at that moment whereby we are deliberating best interests. So this is how, within the hospital, we came up with a policy paper, and we sort of help our junior clinicians put the pieces together in a almost algorithmic manner, right? So that we have pockets of information in a structured manner for thinking. So we'll focus on the part on clinical consideration first, which is very much a deliberation between benefit and harm. Right? And then we'll talk about patients' values and preferences when we deliberate what's best interest. Okay? So again, when you look at all these interventions, some invasive, some less invasive, in our mind, we must ask ourselves, at the end of the day, if I push this patient to ICU, I put in a mechanical ventilator, I tracheostomize this patient, I hook the patient on a dialysis machine, blah, blah, will the patient in the end up like this elderly gentleman in the picture? Okay? And perhaps the bigger question is, if one day something like that were to happen to us or our loved ones, do we want to end up like this elderly man in the picture? Okay? Knowing that he will die in this manner. Okay? So you have to ask yourself, based on what you know of yourself and your family members, is this how we want to die? Right? Is this, a fair bet to wager on? Is the probability of success, worthwhile? Like what we mentioned about quantitative futility, you have to set a numerical threshold about, what is the success rate going to be like and how far you're going to push the boundaries, right? And of course, all treatments and all interventions comes with its own burden, its own discomfort and complications, right? So this simple illustration basically portrays the fact that certain interventions, even when you do it, will just lead to greater burden of symptoms and will not confer any good. There are some treatment that may be worthwhile. There are some treatment that's clearly worthwhile. Where is that point of that sweet point for this patient? And next, we'll move on to the second question, compatible with what? Okay. Now, an attending physician, and that's why consultants are given that salary of a consultant, and if he doesn't function this job, he should step down, right? I'm sure the intensivists would agree with us because many times we will just push the letter to them and say, hey, can you make a decision whether you set this patient to ICU? No, this is not right. Okay, the primary physician should assume that responsibility and decide whether a particular treatment is worthwhile. So the attending physician must weigh the anticipated benefit from these available resuscitative interventions and weigh them against the burden of this treatment. Okay? He must be able to rationalize whether these resuscitative efforts has a good likelihood of prolonging survival, and secondly, has a good likelihood of sustaining the person's quality of life at the end of the day. So again, this weighing of two things. Quantitatively, the probability of prolonging life, and perhaps quantitatively, the likelihood of achieving a certain acceptable quality of life to the patient and perhaps to the family carers. So how do we then decide, what's the likelihood of success? Of course, there are various scales that specialists would use, right? But in a very simple way, okay, this is how we picture it. First of all, you have to determine what is the baseline function of this patient that you're dealing with. Is the patient already someone that's bedbound with advanced dementia, unable to self-care, unable to self-feed on an NG tube? Or is this a fiesty, 35 years old, with a certain heart attack, that can have a lot more runway, And secondly, you have to determine again, what's the severity of this illness? What's the reversibility of this illness? Has he responded to treatment? Okay? And based on knowing where that baseline is and what you anticipate the trajectory to be and what's the probability of you elevating him from that new low, to a better baseline later, you determine whether it's worthwhile. But certain diseases we know leaves an irreversible loss. So for example, a massive stroke, a massive heart attack, right? Certain diseases are progressive and irreversible. Interstitial lung disease, for example, metastatic cancer that's no longer amenable to the newest therapeutics, right? You know that they will leave certain irreversible changes to the organs, and as doctors, we can predict what their trajectory is like. We can't predict to the final hour, the final day, but we can have a rough figure and say, what's the probability of this patient, going to make it through 6 months, a year, a week, and what is roughly their quality of life going to be like, So importantly, this aspect of quality of life comes in. Now, everyone would agree with me, quality of life is subjective, right? So if you have a young mother with metastatic cancer, with 3 children in primary school, everything is worthwhile. right? All the chemotherapy, all the invasive treatment, she may want to undergo it so that she can see her children go through primary school, at least spend every day meaningfully with these children of hers. Whereas if you have a 90 years old, okay, who has completed her family, who is a very good social support, she may tell you, I've lived my life. I don't need to go through these interventions. When it's time, right? So we need to look at quality of life from a subjective manner, as much as possible, eliciting what the patient would have wanted, what the patient would perceive to be the minimum threshold beyond which he wouldn't go ahead with these invasive procedures. When we look at quality of life, if we are unable to elicit, verbally from a patient, you have to have some form of peer review standard, if you may, amongst the community, right? As an average human person, what would you think to be indicators of quality of life? This would be, for example, whether you're able to self-care, whether you're able to perform, basic activities of living, right? Will you be, go to the toilet on your own? Will you need people to bathe you? Will you need people to feed you? A lot of times we take our basic activities of living for granted. Right? I often ask my trainees, what if one day you need a colostomy? What if one day you need an IDC permanently? What if one day you are wheelchair bound? Do you think that life is still worthwhile? Right? And of course, it differs from person to person, from life stages to life stages. Cognitively too, generally we would agree that if a person is no longer able to meaningfully engage his loved ones, maybe his family member, maybe his spouse, maybe his friends, maybe his religious community. But if he's unable to meaningfully identify, engage, and interact, that would definitely be a poor quality of life marker. So I'm going to now give you a scenario to illustrate, this classification that I've mentioned. Right? I'm going to give two separate kind of cases, right? Both involving patients with rather severe liver and gallbladder infection, what we call hepatobiliary sepsis. The sepsis is so bad that the patient has low blood pressure, right, and required quite a number of drains to be inserted into the biliary system to drain out the infected bowel. Okay? The patient is concurrently having pneumonia and respiratory failure, and quite likely will require mechanical ventilation soon if you truly want to push for him to have a surviving chance. He has already turned delirious and he has lost mental capacity, right? So assuming this is a 50-year-old man who, very unfortunately just caught an infection from somewhere, right? He's pre-morbidly ADL independent, his cognition is full, he holds a meaningful job, right? And he has got minimal long-term conditions. There'll be very little doubt for anyone to send him to the ICU, correct? Right? Now I'll illustrate a de-identified case of a recent patient that I saw on the ward, right? That we have to take over. Right? This is a case of a 85-year-old man who is already frail, chair-bound, homebound, some degree of dementia, although he's still able to recognize and interact with family members. He has all these things that we have mentioned common to the younger contemporary. And what's added more is that over the past 1 month he's in the hospital, he has been repeatedly presenting with pneumonia because he has been aspirating because of swallowing impairment. So would you then push this patient to the ICU to be ventilated? Now, apparently, some of us would think that we have very obvious answers in our mind, but a colleague of mine who is handling this patient is rather uncomfortable, and he wants to treat very aggressively. And these are some of his thoughts. He says that, hey, this is an elderly man, if I don't treat him, no one will. Everyone will just brush him aside. If there is even a 1 in 100 chance that I can get him out of this sepsis, I can put in more drains, he may be able to get out of the hospital and spend more time with his family, right? And I'm advocating for the vulnerable and frail, And what for? I call it palliative care. They can only give fentanyl and morphine. And then the patient will still die. We get this a lot on a daily basis, so it's no longer an insult when you get this quite routinely. So the family members actually is distressed. Okay, so they say that my father looks very uncomfortable. We know instinctively he's not going to make it. He's 85. He's been in the hospital for near a month or more, and he's not recovering. We know innately he wouldn't want this, right? Treatment cost is escalating to near $1 million, right? I don't want to be unfilial because the doctor says there's still a fighting chance. If I don't do this for my father, other auntie, uncle, nieces, nephew will come by and point fingers and say, I haven't tried hard enough. And then the surgeon says, don't call in palliative care, they only give you morphine and fentanyl. So this poor patient was being treated with invasive lines, right, through many orifices, right, and was repeatedly treated with antibiotics, with IV albumin, blah, blah, and never quite getting out of delirium, okay, until one day he's really, really at the brink of death. So here's something that I wanted to highlight. When we say that there's a 1 in 100 chance of treatment response, this also means that in order to achieve that 1 in 100 probability of success, you're going to sacrifice 99 other patients' comfortable death in order to be that hero to salvage one person. Okay? When we consider the probability of treatment success as 1 in 100, it means that we have to put 100 similar patients through the same invasive procedures only to see 99 die quite horribly, like the picture that I've shown in the ICU, right? Only with one person potentially surviving. Okay? Now, if you still feel that this is worthwhile, which it might for certain groups of patients, right, in this particular case of an 85 years old with high comorbidity burden, we know statistically too that even if the patient survives the ICU, there's still a very high chance of mortality during his stay in the general ward before he's discharged from repeated pneumonias, infections, myocardial infarction. And even if he belongs to that minority that steps out of the hospital back to the community, almost certainly there will be a great loss to his functional ability to self-care. He'll be even more dependent. There will be greater loss of function. And he will still represent the hospital quite quickly within a year. So is that still worthwhile? Okay, so that's something that I think we have to consider, because the greater probability is that we send this patient to the ICU, he will end up like this elderly gentleman here in the picture, with lines and drains in every orifice, delirious, still unable to recognize family members, unable to speak, unable to eat, unable to pee on his own, unable to poo on his own, right? And is this the way that you would want to die? Is this the way that you want to subject 99 other patients to in order to achieve one success? So lastly, I'll go on to the third part, which is compatible with whose wishes. Now, in the case I illustrated earlier on about the 85-year-old man with hepatobiliary sepsis, whose wishes are you advocating for? Are you advocating for your patient? Are you advocating for the carer? Or are you advocating for yourself? Are you treating the patient or treating your own personality? Now, when we look at best interest from the perspective of the patient or the immediate family carers, okay, we have to, of course, consider what the patients have expressed before, right? And of course, if he has not expressed something similar, are there family members or loved ones who know this patient well enough to postulate and to extrapolate, what this patient would have wanted in such a set of scenarios? And of course, we have to bank on a few things: ACPs, advanced directives, any goals of care conversations that were documented in this admission or previously. Okay? And generally in a patient that is still possessive of mental capacity, so in the 85 years old with hepatobiliary sepsis, if the patient has certain lucid moments that I can speak with this patient, you'll be pertinent to ask, how are you feeling now? Things are not working so well. We have put quite a few drains in you. Do you think that if you turn worse, you want us to put in more drains, put in more tubes to give you a fighting chance? Or do you feel that keeping you comfortable is more important? Now, it's important to remember that if the patient consistently and clearly tells you that he doesn't want it, and he gives you good reasons for not wanting it. So in a Singaporean setting, it may be that I'm old already, I don't want to be a burden to my family. I live a long life, my family is complete, I'm okay. So if they say something to the extent that's consistent, then you have to respect the patient's autonomous decision. And if you don't, you violate the law. Okay? You'll be tantamount to assault. Okay? Because you're imposing something that the patient do not want on his body. Right? So it's similar to assault. Okay? And number two, if there is an irreconcilable difference, you can't convince this patient otherwise. For example, let's say this elderly man with 85 years old with very bad sepsis wants all-out ICU care, and you feel that the chances are too low, and you can't touch your heart and say that this is in the best interest of the patient medically. you are not professionally obliged to provide medically inappropriate treatment, even if the patient demands for it unilaterally. Okay, it's a tough call, but you have to make the judgment. Now, in a patient who has lost capacity, of course, then you look at what he has said before. Is it captured in an AMD? Is it captured in an ACP? And then you consult the patient's significant others as required under our Mental Capacity Act. Okay? And in a patient who lost capacity, and if there is truly, irreconcilable difference in opinion between you and the spokesperson or family members, again, under Singapore's laws, okay, and quite uniquely to Singapore, you need not concede to the unilateral demands of family member, but you have to justify why you think that this is not in the patient's best interest. Okay? Now, rather than that, the physician must act in the best interest of the patient and administer treatment that's medically appropriate. So I'll jump the gun a bit. I'll just eat into Dr. Chan Mei Yuk's talk just a little bit. Okay? So some of us may not be aware that actually Singapore's Mental Capacity Act actually quotes the UK one almost verbatim, word to word. Okay? Up to recently, there was some revision on the UK side, but before this, it was almost a word-to-word repeat of what the UK MCA is. One of those minor differences is highlighted in one small section. And here's the one section here that basically says that even if the patient has a lasting power of attorney and has allocated a donee to be his or her healthcare spokesperson, the donee is not authorized to make decisions with regards to life-sustaining treatment. This does not refer to extraordinary life-sustaining treatment as depicted in the AMD. It refers to any treatment that prolongs life. So if you infer from it loosely, this could include anything that we have discussed earlier on, IV drip, IV antibiotics, inotropes, NG feeds, blah, blah. Okay? And it goes on further to say that any other treatment which a person providing healthcare reasonably believes is necessary to prevent a serious deterioration of patient condition. So it goes beyond that to say that these may not even be life-prolonging. Okay? The donee does not have the legal authority to demand. But legally, we are obliged to engage the significant others in this conversation to decide what the patient would have best wanted, what the probability of success, what is the likelihood of sustaining an acceptable quality of life. And that will constitute your best interest decision. So if ever questioned, by a peer or in court by a professional body, the important point is to justify what we think is the best interest and justify it according to these things that we have mentioned as a summary, right? Number one, what's the probability of treatment success? What's the probability of achieving an acceptable quality of life? And by quality of life, how did we then come to the conclusion? Is this from the patient's words, inferred from the carer, or based on a very overall, average person on the street, because we just cannot find someone to elicit what the patient had wanted. So long as you are able to justify along all these three lines, again, by Boland's law, you do not need to have everyone agree with you. So long as you have a professional body that agrees that this is standard of care, it doesn't matter if someone else holds a deviant view. Okay? So long as you can justify to the court that this is rational, this is logical, this is standard of care, you're cleared. And that should not stop you. The fear of medical legal backlashes should not stop you from acting in the best interest of this patient. Okay, I think that's my last slide. Thank you very much.